I think we're good to start. So good morning, and thank you for being here on a Friday morning. It's my pleasure to reintroduce Dr. Kristien Boelaert. She's a professor of endocrinology at University of Birmingham, UK. We already had fantastic talks by Dr. Kristien yesterday. So today's state-of-the-art lecture is thyroid disorders in pregnancy, a very sensitive area, I should say, in pregnancy. So Dr. Kristien.
Good morning again, everyone. And for a final time, thank you for asking me to be part of this conference. Right, thyroid disorders in pregnancies. Here are my declarations. So what I'm going to talk to you about first is changes in thyroid function and thyroid autoimmunity in pregnancy, because this is essential to understand so that we can interpret thyroid function tests in pregnancy, because they are different from outside pregnancy. I have 3 clinical cases to illustrate, firstly, thyrotoxicosis and hyperthyroidism, then management of hypothyroidism, and then what do we do with autoimmunity before and during pregnancy. So during pregnancy, there are a number of physiological changes. There is, as HCG rises, and HCG is structurally very similar to TSH, there will be a drop in TSH and a slight rise in free T4. And this peaks at around week 10 of gestation. And so this graph here nicely illustrates that. So HCG rises, TSH will drop, and free T4 rises. Because estrogen stimulates the liver to produce more thyroxine-binding globulin, you will have an increase in binding proteins for thyroid hormones, so the amount of total thyroid hormones will rise very significantly. And again, you can see that here. The fetal dependency on maternal thyroxine is highest in the first 20 weeks of pregnancy, but this lasts throughout pregnancy. And with advancing gestation, you also have increased degradation of thyroxine by the type 3 deiodinase enzyme and increased iodine clearance. So a number of changes here that require us to take this into account. And so the reason for illustrating this is that what the recommendation is that most centers should use trimester and pregnancy-specific thyroid function tests, so different reference ranges for pregnant populations. Thyroid autoimmunity also changes in pregnancy. So these are data from Tim Korova. So as you know, TPO antibodies are present in a large proportion of the general population, but they definitely are present in up to 17% of unselected pregnancies, and they are present in higher concentrations in subfertile and in those populations with recurrent miscarriage. So usually what we see in TPO antibody negative women, which I illustrated on the previous slide, is a rise in free T4 and a drop in TSH. However, when TPO antibodies are present, these changes are no longer present. So again, thyroid autoimmunity helps us to interpret thyroid function tests during pregnancy. And the gestational response is different depending on the TPO status of patients. So again, something to take into account. So as I said, what most guidelines recommend is that you use trimester and population-specific TSH reference ranges. Ideally, these have been determined in TPO antibody-negative women without any thyroid illness. Now, that may all be very easily said and done. If that is not possible, I urge you to know what assay you use in your center, and try and use pregnancy-specific reference ranges using a similar assay in similar populations in order to interpret thyroid function. And if this is not possible, then generally what's considered the upper limit of normal for TSH in pregnancy is 4. So moving on then to the first clinical case, so I'll need a bit of audience participation here. This is a 28-year-old woman with Graves' disease. She wishes to become pregnant. She was diagnosed 18 months ago. Her TSH receptor antibodies were significantly high at diagnosis, so 5 times the upper limit of normal. She still is on metimazole 30 milligrams a day, but is clinically euthyroid with a small goiter. Her thyroid function test showed that thyroid toxicosis is controlled, but TSH remains suppressed. So free T4 towards the upper end of normal and total T3 also towards the higher end of normal. So this woman wants to become pregnant, and so it's not necessarily that all answers here are mutually exclusive, but what do you do? Do you continue metimazole? Do you change to propylthiouracil? Do you advise radioactive iodine? Do you advise total thyroidectomy? Or do you discontinue anti-thyroid drug treatment? So any takers for A? B? C? D? Or E? So one taker for E, and most of us would go for B. So I would probably change to, so I think it depends here how soon this lady wants to become pregnant. She's 28, so she still has time on her hands. If she says, I want to have this sorted, then maybe a total thyroidectomy is a good option, because it's infinitely easier to manage hypothyroidism in pregnancy than hyperthyroidism. I would not advise for radioactive iodine because TSH receptor antibodies will rise, and I would not continue her on metimazole. So new onset thyrotoxicosis in pregnancy really is exceedingly rare. And 90% of cases of new onset thyrotoxicosis is gestational transient thyrotoxicosis. And it's really important that you distinguish these. So this is a self-limiting condition. Usually thyroid function tests normalize once HCG levels come down. There were no adverse outcomes associated with this, and it's much more common in women with hyperemesis gravidarum or in twin pregnancies because of high levels of HCG. Often, how do you distinguish? Often these patients don't have a family history of thyroid disease, but for me the most important thing is, did they have symptoms before pregnancy? Because if they didn't, then almost certainly this is GTT. You can biochemically do it, because often T3 will be normal in gestational transient thyrotoxicosis, and TRAB antibodies will be negative. So those are your biochemical tests to help confirm that. And obviously, quite often these patients don't have eye signs and may not have a large goiter. Graves' disease in pregnancy, however, does need treatment. So GTT requires supportive treatment. Graves' disease does require treatment. And untreated Graves' disease is associated with significant maternal risks of thyroid storm and congestive cardiac failure, but importantly, pregnancy loss. And this is reported about 45% in women who are not treated. So unfortunately, we don't have very good data on management of Graves' disease in pregnancy, and these data are from 1994, so quite old, but actually more recent studies show very similar outcomes. So this shows here the rates of adverse outcomes: low birth weight, prematurity, small gestational age, and severe preeclampsia, which on all occasions is significantly higher in those women who were uncontrolled, slightly lower in women who were controlled at the end of pregnancy, but the best outcomes is when thyrotoxicosis is controlled during pregnancy. And certainly when I have my consultation with women of childbearing age, I say, try not to become pregnant whilst your thyroid function is very uncontrolled. Like I said, more recent data show that there is still a residual risk with good control, with increased rates of placental abruption and cesarean delivery. So what about the choice of anti-thyroid drugs? And because that's again what this case illustrated. So the original data came from Japan, looking at differences in teratogenicity, comparing metimazole and propylthiouracil. So this study here of about 2,000 women showed that there was a significant increase in fetal malformations in women who had taken metimazole before and during pregnancy, and this was not present in propylthiouracil. We have further data from the Danish database, which actually showed that also with propylthiouracil, there is an increased risk of fetal abnormalities. The risk is lower than with carbimazole, but it's definitely not present, and those women who were not exposed to anti-thyroid drugs had the best outcomes. So with metimazole, you get what's more an embryopathy, so a syndrome of various abnormalities: choanal atresia, aplasia cutis, omphalocele, and often these defects are much more difficult to reverse than the ones you get with PTU, which tend to be milder and often tend to be just located to one organ, such as a preauricular cyst or a hydronephrosis. The best data on anti-thyroid drugs and congenital malformations we have are from Korea, So this is a Korean database looking at nearly 3 million pregnancies, where you can see a large number, over 2 million live births, in which nearly 13 pregnancies were exposed to anti-thyroid drugs. So exposure to anti-thyroid drugs resulted in increased risk of birth defects, 7.27% versus 5.94%, so an odds ratio of 1.19. Risks were there with propylthiouracil, with an odds ratio of 8.81, but definitely this was higher in metimazole. So what this study showed was that when women had been exposed to metimazole and then changed to PTU, actually their odds ratio stayed the same, so it didn't actually make much difference. As I discussed yesterday, I still do that because it sort of makes me feel better. I'm not sure it necessarily makes much difference to the patient. Importantly, what this study showed was that it's the dose that matters. So a high cumulative dose was associated with significant increased risk. So always try and treat with the lowest possible dose. Sometimes you can stop if thyrotoxicosis is controlled, stop it in the early part of pregnancy. So pre-pregnancy, and again, like I said yesterday, if I have the luxury of knowing someone is going to try for pregnancy, which is less than 50% of my population, I change to PTU. In the first trimester, I try to keep them on PTU. If we still need anti-thyroid drugs in the second trimester, I will often change back to carbimazole because I do worry about PTU-induced liver toxicity. I have dealt with a few cases of hepatotoxicity and it's really not very nice. Often, however, Graves' disease gets better in pregnancy and I stop anti-thyroid drugs. I tell patients that it's likely they will relapse after delivery, and that is indeed what we see. So lowest possible dose, maintain the free T4 in the upper half of the normal range when you monitor it, even so this patient who still has an undetectable TSH, so TSH really often doesn't help you. So keep free T4 in the upper half of the normal range, and these are women where I really keep a very close eye on thyroid function tests. So anyone who's actively treated with anti-thyroid drugs has a 2-weekly test in my clinic. So we touched on this yesterday because I had a question on this, but effect of treatment options on TSH receptor antibodies. So again, these are data from Denmark here, where you can see what happens to TSH receptor antibodies following radioactive iodine, surgery, or anti-thyroid drugs. And you can see that following radioactive iodine is actually a significant rise in the levels of TSH receptor antibodies, and they stay very high for long periods of time. So that is one of the reasons why that needs a very careful discussion with this patient if she wants to go for a definitive treatment before becoming pregnant. So this needs to be part of the counseling that you do. Antibody levels still remain high following surgery and medication, but they tend to drop much more quickly. So the fetal hypothyroidism is what we fear here. So antibodies crossing the placenta. The fetus from about 16 weeks has a fully formed thyroid gland. It takes about 20 weeks before that becomes responsive. But so once TSH receptor antibodies cross the placenta, this results in thyrotoxicosis in the fetus. And really, this can be a devastating condition to deal with. So again, it's the level of antibodies that helps us here. So this study looked at antibody levels during pregnancy and then what happened to the neonates when they were born. And so here when antibody levels were higher and the cutoff here was 3 times the upper limit of normal, the risk of neonatal hyperthyroidism was significantly higher, and this had a very good sensitivity. So all patients who have ever had Graves' disease, regardless of whether they're cured or not, have TSH receptor antibody testing in my clinic at the first time that I see them. Patients who are actively treated, or those where antibody levels were high, will have it repeated at 20 weeks, because at 20 weeks is where I make a decision how closely are we going to monitor this fetus. And so if TSH receptor antibodies are high, then we do more regular fetal ultrasound scanning, and they have weekly fetal heart rate called auscultation, so much more close follow-up in those where antibody levels are 3 times or more the upper limit of normal. So check it at baseline, repeat at 20 weeks. American Thyroid Association guidelines, which we're rewriting at the moment, say to repeat it at 28 weeks. I'm not actually really sure that makes much difference to my management, so I tend not to do that. Right, that's hyperthyroidism. Second case, 32-year-old woman, 8 weeks pregnant, has had 1 previous miscarriage. She's got a raised BMI and reports bloating and tiredness. So she has a TSH that's towards the upper limit of normal, 3.8. with a free T4 of 11.6, so towards the lower end of normal, and TPO antibodies are not raised. So do we send this patient on our way and say you can just be followed up by the midwife? Do we repeat our function test after 4 weeks? Do we wait till 20 weeks to repeat it? Or do we start her either on a low dose or a higher dose of levothyroxine? Any takers for A? B? C? D? E? I think lots of people are undecided. I would probably just repeat it at 4 weeks. I might send her to, in principle, I could just send her to the midwife and say, this is fine, you don't need this. Probably I'll feel a bit nervous, and because that TSH is towards the higher end of normal, 3T4 is towards the lower end of normal, so I'd repeat it at 4 weeks. Repeating at 20 weeks, I mean, what you do after 20 weeks probably makes very little difference to outcomes, so probably not, but I would not start levothyroxine here, importantly. So the tablet trial, which I was part of, and I'll come back to when I talk about autoimmunity, but this gives a very good opportunity to look at the prevalence of thyroid dysfunction in a pregnant population in the UK, because we had to screen 20,000 women in order to recruit for the tablet trial. And you can see that actually overt thyroid dysfunction was very, very rare in these people. However, what we're focusing here is on very mild hypothyroidism. So you can see that subclinical hypothyroidism, depending on how it was defined, could be present in about 20% of people, if we define it as a TSH over 2.5, but was only present in a much lower proportion if we define it as a TSH that's greater than 4. We found that TPO antibodies were present in about 9.5%. So, but importantly here, if you bring down this TSH level to 2.5 as the cutoff of normal, 1 in 5 women that you see will require levothyroxine treatment, and I'm not sure that that is the correct approach. So the current ATA guidelines, which, as I said, I'm almost certain this will go and will be revised, but I'm part of the ATA panel setting the guidelines, so I'll try and make sure this goes. But in TPO antibody positive women, if TSH is over the reference range, we recommend 3T4. If it's between, we recommend levothyroxine replacement. If it's between 2.5 and the upper limit of the reference range, it says to consider levothyroxine, but don't treat with a TSH less than 2.5. If TPO antibodies are negative, as you would in a general population, treat with a TSH over 10 and consider it with a TSH that's higher than the reference range, but less than 10, but not for a TSH less than 4. So the patient I illustrated had negative TPO antibodies, so I'd still be in concordance with these guidelines here, but I'm not sure whether this will stay even in the new guidelines. So a number of meta-analyses have looked at what happens to preterm birth and other adverse outcomes in patients with thyroid dysfunction. This is the largest one published by Tim Korovar in 2019. You can see this is a very large number of patients from 19 cohorts. And you can see that in both subclinical hypothyroidism and isolated hypothyroxanemia, there was an increased risk of preterm birth. So isolated hypothyroxanemia is quite a specific condition to pregnancy. It's where you have a normal TSH and a low T4. Outside the setting of pregnancy, this makes us think that there may be pituitary disease. However, in pregnancy, this often is an interference in the assay that makes the T4 read quite low. So often these women have become spontaneously pregnant, so it's unlikely to have significant pituitary disease. But again, so you can see that this is associated with increased risks of adverse outcomes. Further studies looking at obstetric outcomes in subclinical hypothyroidism. So again, here a systematic review looking at pregnancy loss, which was significantly higher in women with subclinical hypothyroidism, as well as risks of placental abruption, premature rupture of membranes, as well as fetal and neonatal death. So what about studies looking at treatment of this then? And unfortunately, with regards to obstetric outcomes, we don't have any really good clinical trials. This is a database study that looked at 5,000 women with subclinical hypothyroidism, and which showed that if you treated these women, that there was indeed an improvement in pregnancy loss. However, levothyroxine, and this is the first study that indicated that maybe there may be harm from giving these women levothyroxine, was that there was an increased risk of preterm delivery, gestational diabetes, and preeclampsia. Because often I thought, well, as long as we're not doing harm, does it really matter that we give this woman a little bit of levothyroxine? It makes her feel better because she thinks we're doing something. It makes me feel better because I think I'm doing something. But actually, maybe we're causing harm, and that is something really important to consider. So this is a further study. So this looked at a general population that were taking levothyroxine, and we're notoriously bad at treating women or people with hypothyroidism, and TSH is often not within the reference range. But again, this indicated that in a general population, when they looked at obstetric outcomes, that there was an increased risk of preterm delivery in women where TSH was very, very low, so who were overzealously treated with levothyroxine. So again, potential harms here. So we look at obstetric outcomes, we look at neurocognitive outcomes, because we know that for normal brain neurological development of the fetus, it's important that there is sufficient thyroid hormone there. And we've actually had 2 nice trials looking at neurocognitive outcomes in people treated with levothyroxine. So treatment of subclinical hypothyroidism or hypothyroxinemia in the CATS trial. I must say this was treated with quite a high dose of levothyroxine. They started at a median week of 13 weeks of gestation, and IQ was tested at 3 years. So both this trial and the KC trial in the United States were negative. There was no effect on neurocognitive outcomes. Criticisms, certainly here the dose I think was too high, but actually it was too late. If you start at 13 weeks, it's too late. You've missed the boat. The KC trial was even later at 17 weeks. And secondary analysis showed no differences in obstetric outcomes. And again, further evidence here that you might actually be doing harm by over-replacing people comes from this study from the Netherlands, where we had nearly 4,000 mother and baby pairs. Mothers had a thyroid function determined at less than 18 weeks of gestation. And at a median age of 6 years, the children had their IQ scored, and you can see this inverse U-shaped curve. So both with 3T4 that's low, but also 3T4 that's high, there are worse neurocognitive outcomes. And further evidence that looks at what happens if you actually have very high T4 and child IQ and behavior. Again, here from the Danish database, an inverse U-shaped curve, where you can see that both with low and high T4, there are adverse outcomes on child's verbal IQ. And this is a secondary analysis from the CATS data that looked at ADHD. And again, with higher levels of T4, there was an increased risk of ADHD. Further studies confirming that this may be associated with autism and epilepsy in the offspring. So overzealous treatment may actually have adverse effects. And then finally, the third case, again, similar to the previous one, a 32-year-old woman who's 6 weeks pregnant. She conceived via IVF. She's had 3 previous miscarriages, slightly overweight. Her thyroid function is normal. TSH is actually quite normal, 2.4, with TPO antibodies that are raised. And again, it's the same possibilities you have as in the previous option. Anyone for A? B? C? D? A few? E? I would discharge her. I'll show you why. So again, same systematic review, meta-analysis, IPDM that was done by Tim Korovar, looking at a large number of patients, but this time taking TPO antibody status into account. Again, showing at the previous forest plot I showed here was higher adverse outcomes with subclinical hypothyroidism and isolated hypothyroxinemia, but this was particularly pronounced in people who were TPO antibody positive. So preterm birth, definitely when TPO antibodies are present, it seemed to be slightly higher when TSH was greater than 4, and was present equally where the TSH was in the normal range or greater than 2.5. So here we actually have a number of trials. We have a trial in the fertility population. So this is a trial from China. women, 600 women undergoing IVF egg transfer. The primary outcome was miscarriage rate at 28 weeks, and again, this was a negative trial. So women were randomized to either not receive levothyroxine or receive levothyroxine, so they are TPO antibody positive, have normal thyroid function. We give levothyroxine, no effect on fertility outcomes. That's the bottom line of this study. The tablet trial. This was looking again at obstetric outcomes. Our primary outcome was live birth greater than 34 weeks. So this, I was part of this study published in the New England Journal of Medicine. Again, this was flat, okay? Treating women with positive TPO antibodies, normal thyroid function with levothyroxine does not affect outcomes in with regards to live birth or any of the secondary outcomes we looked at. So miscarriage, early miscarriage rates, ongoing pregnancy, ectopic pregnancy, none of it was affected. So there is no doubt that when you have TPO antibodies, there is an increased risk of adverse fertility and pregnancy outcomes. It does not appear to be driven via affecting thyroid function. So this may just be part of a larger autoimmune effect that is there. I would love to do a trial where maybe we give steroids to sort of combat autoimmunity, but it's not improved by levothyroxine. So the case I showed, we can just discharge. There is no evidence that doing anything with levothyroxine here makes a difference. I probably wouldn't repeat her thyroid function at 4 weeks either. So, in conclusion, I think I just have about a minute for conclusion. So it's really important that you discuss all these issues with the patient, discuss the impact of autoimmunity and its treatment on fertility and pregnancy, interpret your thyroid function properly during pregnancy. Good control of thyroid function and assessment of TSH receptor antibodies are crucial in women with Graves' disease. Levothyroxine replacement in mild hypofunction is not consistently associated with improved outcomes. There is evidence that overzealous levothyroxine replacement may actually cause harm. And please stop giving levothyroxine to women who have raised TPO antibodies with normal thyroid function. It makes no difference. We have good trials to confirm this. Thank you.
Thank you, Dr. Boelaert, for such a clear and concise presentation. I'm sure we have some questions.
Thank you, Kristien. Excellent presentation. Very nice review, very important subject. Just practical question. The last case, I think, was about fertility, IVF, and like that.
Yeah.
You already have the patient already pregnant. I would ask you if this was not yet pregnant and coming to your clinic for planning for the IVF, they send it to you, and you have the antibodies positive, and the TSH, again, in the high normal range. That's a scenario.
Yeah.
I would like you to comment on that.
I get a lot of questions from my fertility colleagues regarding this. I don't think there is good evidence that it makes a difference. There isn't, if that TSH is higher, if it's, towards the upper limit of normal, does giving levothyroxine cause that much harm? Possibly not. So in some of those patients, I may start a lower dose. I think in this case, the TSH was really very, very normal. And TPO antibody levels, if anything, weren't really that high. But so it's certainly a big work package of the new ATA guidelines that we're looking at, what we do in the fertility population, because certainly the European fertility guidelines probably would treat.
Right.
So, but the trials we have show that it does not impact outcome, regardless of even TSH that's towards the higher end of normal.
Right. In a follow-up to this, in view of that, the TSH, a little bit changes might make you decide. And there are people talking about the time of testing your TSH.
Yeah.
Would that something that you consider, whether it's done, in the morning or done other time?
Yeah.
In sensitive cases like these?
So unfortunately, I work in a system where I don't have that luxury. If I have to start telling people or phlebotomy services or GPs, take this TSH at an appropriate time of the day, I'll be shot. There is no way I can do that. There is evidence that taking TSH in the morning is slightly different to what's in the evening. So in these, carefully managed patients. If you have the luxury of doing that, that's fine. That is not a reality for where I work. You know, having a TSH done by a GP is a great achievement in itself. Telling them what time of day, you know, my husband's a GP, he will say, yeah, forget that.
Okay, just last, if I may, last question. The case you presented with thyrotoxicosis coming in early pregnancy. Now, if you have somebody, which again, this is really a puzzle to most of us coming to us to decide whether it's Graves' disease or not. The TRAB is negative, right? And that's help you. But you mentioned something about hyperemesis, if they have it directly to a different opinion about treatment. What if they don't have nothing? None of all this, no symptoms at all, no hyperemesis.
Okay.
No signs of that. But again, the point you mentioned, T3 is normal, but I have seen cases T3 is not normal, is higher than normal. Would that make you decide differently?
Sorry, so
the free T4, actually TSH is suppressed, T4 is slightly above normal range, and also free T3 is slightly above. But you do the TRAB, it's negative.
it's negative. And the patient has no symptoms, and did not have symptoms before pregnancy.
Right.
Sit tight and watch.
That's what I did, so I am
Yeah.
okay. Okay, thank
So
you.
if the patient is very symptomatic, I do use beta blockers. So generally obstetricians don't really like beta blockers in pregnancy. I think it's mainly the third trimester of pregnancy. Yeah. And when I first wanted to do this, they were like, oh, we don't like using beta blockers. I'm like, well, you use labetalol for your patients with hypertension. So I would give some beta blockers, but I would sit tight and monitor.
So you still use Inderal or you use bisoprolol, you're saying here? Which one you use?
I prefer propranolol.
Yeah, okay.
But if that's not possible, then I use bisoprolol. If they're asthmatic, I use bisoprolol.
Thank you very much.
I guess we'll take the microphone on the left.
Yeah, thank you very much. Now, in a patient whose TSH is more than 4, and then we have problem with accepting the TPO from the insurance company. So you have TSH more than 4, and then you have the inability to do the TPO. What you will do?
Probably give a little bit of levothyroxine.
Okay, thank you. My next question, there are obstetricians who use steroids for positive TBO. What is your intake in that?
So I would love to do a proper trial on that. There is no clear evidence that works. I can physiologically see it, and I actually think the reason why TPO antibodies result in these adverse outcomes is because this is sort of generalized autoimmunity, results in implantation difficulties and that sort of thing, but we don't have clear evidence. So I don't think it's something we can recommend. A lot of these women who come from fertility clinics, certainly the private fertility clinics where I work, much to my disgust, have been put on steroids in order to improve their fertility outcomes. So when they've been started by their fertility specialist, who am I to say stop it? I tell them that I don't agree that that's the right thing, but a number of them are already on it. It's not something I would start. I would love to do a trial.
Thank you.
Thank you. Well, I'm not the expert in your field. I'm pediatric endocrinologist. I want to challenge your decision about case number 3. I'm sorry. So autoimmune thyroiditis is a progressive disease, and you showed your patient has positive antibodies, week 6 of gestation. In my practice in adolescent patients, I do follow them, at least to show that there's no trend toward hypothyroidism, and if I don't see it after the second test, I will basically sign them off. This is the first set of thyroid tests on your patients. Anti-TPO is elevated. Why would you not repeat in weeks?
Yeah, I take that. Repeating it after 4 weeks is not wrong. Again, the system where I work, because we don't have any clear evidence, we properly discharge this patient. But often in these cases, like I said, often answers are not mutually exclusive. I think giving high-dose levothyroxine to this patient, I would say that's definitely wrong. Repeating it after 4 weeks, if your insurance pays for it, it's fine. I'll forgive you for that.
Thank you for your excellent talk. So we measure thyroid-stimulating immunoglobulins, and they are high in a pregnant woman. We're worried, she's worried, we're doing the scans. What else will we do that will change outcome?
Nothing really. So it's about monitoring these patients. I've dealt with a few patients where there is really significant. So often they've come from other centers, very high levels of TSH receptor antibodies. The baby, they're transferred to my specialist center when the baby is already in trouble. So on 2 occasions I've had this where the woman is actually hypothyroid after radioiodine. In one occasion, this was 8 years ago, she had radioiodine, still at high TSI, and it's then a balancing act of treating the moderate levothyroxine and give anti-thyroid drugs. So the reason why we don't recommend the block replace regimen for treatment of hyperthyroidism in pregnancy is because anti-thyroid drugs preferentially cross the placenta. So if you give a block replace regime to this woman, then the anti-thyroid drugs will go to the fetus. Outcomes are not necessarily good, it's really, really difficult. But there is very little you can do. If I had something to get rid of those antibodies, I would do it, but there have been a handful of studies looking at plasmapheresis and that sort of thing. I don't know what I've done in a few patients where this has happened. So recurrent miscarriage, very high levels of TSI. I've actually, when they then try for a pregnancy, so before they try for a pregnancy again, removed the thyroid gland. Well, I haven't removed it, but I've asked somebody to remove the thyroid gland surgically, because once you remove the antigen, antibody levels will come down.
Thank you very much, Dr. Boelaert, for the great presentation. And I think levothyroxine works very well for patient and doctor anxiety.
Sorry.